Good day and good evening, everyone. I'm Dr. John Ward, Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health in the United States. It's my pleasure today to bring together a number of experts on hepatitis prevention, testing, care and treatment, and management of liver disease to give us a pulse check on our progress toward hepatitis elimination in the Asia-Pacific region. I'll be introducing a number of my colleagues who will be giving you the latest information around hepatitis elimination in Asia. As far as housekeeping is concerned, the coalition is the host for this webinar. All the information about from this webinar will be on our website at globalhep.org. For our event this evening, or today, which will be lasting for about 90 minutes, please submit your questions to the Q&A feature of Zoom. The webinar will be recorded and posted on our website along with the slide presentations. And I encourage you while you're there to sign up for our newsletter, which is issued monthly, to help you stay abreast of what's going on around hepatitis elimination around the world. Here's our agenda for today. I'll be joined in the program with Professor George Lau from Hong Kong and from his medical appointment, as you can see there in Beijing, representing the Elimination Work Group from APASL. And then you'll be hearing from Professor Grace Wong, Professor Zhang-Ki Choi, Professor Kidia Puvaran, Professor MLU, and Professor Yu Kuo Chow. And then we'll be having some opportunities for discussion thereafter as time permits. The coalition, one of our main functions is to bring people together to share lessons learned, experiences, so that we can all be better informed. And through working together collectively, we can get more done on our individual task of advancing progress toward hepatitis elimination through prevention, testing, care, and treatment. Over the course of this year, we have held regional forum in Africa, in Cairo, in June, in Europe, in Vienna, following the APASL meeting. And then the subject of tonight is that we had a regional forum at APASL in February in Taipei, and we thought it was a good opportunity to do a mid-level update of progress toward elimination as we look ahead toward APASL in 2024. At the regional forum at APASL in Taiwan, you can see the agenda there on your left, looking at just sort of the general models of care for hepatitis C in particular, and looking at particular marginalized or populations that are particularly at risk for hepatitis C, and perhaps the ones that are have the most difficulties in reaching and receiving hepatitis C care and treatment. We also brought together a call to action there to really highlight the key services that need to be in place to reach elimination goals, that includes good data for policy development, good access to prevention services for the highest risk populations, such as people who inject drugs, and access to reliable testing with strong linkages to care, and access to the curative direct-acting agents. And you can still connect with that call to action with that QR code listed that's provided here. There's also been a very nice summary written by the authors that are here, providing some of the high points of those discussions during that regional forum. And so I encourage you all to take a look at those. So let's get started on today's update. It's really my great pleasure to introduce Professor Grace Wong from the Chinese University of Hong Kong. Grace, I'll turn it over to you.
Okay, thanks, John. Yeah, hello, everyone. So it's my great pleasure to give a short presentation to share with you the progress, the work of all the healthcare workers and also many other parties in Hong Kong try to eliminate hepatitis C. So some of my personal financial disclosure, which will not affect the content. To start with, I'd like to give you a big picture of the disease burden in Hong Kong. Hong Kong is a small city of 7.5 million population. The prevalence of Hep C in Hong Kong is not high, it's 0.3%. So that you may say that the disease burden in Hong Kong is not particularly huge. 5 years ago, we have this multi-center study. We put together some real-world data and try to estimate how many patients we have yet to diagnose and treat. To cut the long story short, at that time point 5 years ago, we were not yet meeting the WHO goal because no matter the screening rate, diagnosis rate, treatment rate was quite fell behind. So I think that is a kind of good message, a warning sign for us. We should work harder. So we have been working harder. So in fact, on the same year, is that our government established this steering committee on prevention of control of viral hepatitis with many high officials and experts in Hong Kong. In fact, among those would be some key academic like my two mentors, Professor Henry Chen and Professor Vincent Wong. They have been giving a lot of high-level advice and form some working groups, which the working group will also be responsible to organize some down-to-earth policies, like myself and Professor Vincent Wong will be the members of clinical working groups, in which that we would try to implement some action plans to provide service, staff training, importantly linkage to care of patients who have been diagnosed and provide very cost-effective treatment. These are our road. So back 3 years ago, it was still the time that COVID just started not long ago. Our government still committed themselves to have this very first Hong Kong viral hepatitis action plan, which lasts for 5 years, to offer a lot of very important plans in 4 domains, like to raise the awareness, to provide regular survey of local indicator of disease, to provide prevention, and very important, to treat patients. So these are the things that we have been doing. So one thing I would like to introduce is some partnership with our NGO. In fact, this program, New Life Liver, organized by our university as well as some NGOs, have been in place for more than 14 years. In fact, we have been working closely with our NGOs to provide public education. At the same time, we do the point of care testing to screen subjects at risk. We also have a lot of media exposure to educate our general population because, in fact, Hep C awareness in Hong Kong has been quite low over the years. And also, I would like to give my tribute to late Dr. Nancy Leung at the lower part of this slide. In fact, she was the founder of another important NGO, Asia Hep, which again give a lot of live screening, testing, media activities, which also would raise a lot of awareness. One of the things is this large-scale screening that we organize and diagnose a lot of undiagnosed subjects. So over the years, we work together with our NGOs, and one of the, I would say, quite successful program is this Test to and Treat program, which are recently in place because we now have the very good point of care H0 RNA. So everything can be done within just half a day. We invite our subjects at risk and do the screening tests. At the same time, we provide education, assessment, like transient elastography, and then after the result available in like 40 to 50 minutes, then we can start the treatment, DAA treatment right away. So in fact, with this program, in fact, we can really streamline all the steps and everything can be done within one morning that, in fact, the patients feel very satisfied and also the treatment uptake rate will be very high. So I will say I close a very short summary of our program in Hong Kong. We have been working very closely with NGOs, and we find that the streamlined referral and care pathway can definitely increase the treatment uptake. So I think this is something that from our pilot program, we are now offering more information to our government. Hopefully this kind of point of care testing and also streamlined referral pathway can be in place, generalized for all citizens in Hong Kong. So with that, I thank you very much for your attention.
Oh, thank you very much. That was a very quick but thorough overview of your program. One quick question for follow-up. Many other programs really have a challenge of getting people on treatment after they receive a diagnosis based on a virologic test. You didn't show a care cascade, but could you give us a little bit of a sense of the success rate of getting people on treatment after diagnosis?
Okay, thank you, John. Yeah, I think if we refer to that half-day program that I just mentioned, in fact, the treatment uptake rate will be 100% because they are right there. So they are right on spot. They receive education assessment, and they would be very happy to receive the treatment because we explain to them clearly how the treatment will benefit them, the very, very high SVR rate and so on. But this only refer to this particular program. But if more general, for example, if we have to split the assessment into different visits, for example, we have conventional blood test first, and then another 2 to 3 weeks later, we ask them to come back to see the result and start treatment. With this conventional approach, we usually will lose around 10 to 15% of the subjects because they just lost the follow-up. They do not show up. So I think that conventional approach will, on every single step, we will lose some patients. So that's why if we have like 2-step, 3-step, then cumulatively we may lose 20 to 30% of our patients who have been diagnosed to have active viremias. So that's why I will really support this kind of streamlined half-a-day program, which can really do everything at the same time. So we'll minimize the loss to follow-up.
Right. Thank you very much. Excellent. Well, let's move on now, and we can have some more questions as we move along. So thanks again, Grace. Great job. So Lindsay, can you go to the next slide, please? Well, fantastic. It's my pleasure to introduce Professor John Ki Choi, who's assistant professor in the Department of Gastroenterology, Liver Center, as in Medical Center, University, Ulsan College of Medicine in Seoul. Professor Choi.
Do you see my slide?
Yes, if you can just put it in presenter mode. Perfect.
Excellent. Excellent. Perfect.
Okay, great. I'm Jong-Ki Choi from Asan Medical Center, Seoul, Korea. Thank you for having me on this great webinar session. For the next 10 minutes, I'm going to talk about the status of the hepatitis C elimination program in Korea, mostly focusing on recent policy and then some updates for the HCV care cascade improvement. I'll start with this graph indicating where we are in the journey of HCV elimination. In Korea, among the target goals by the WHO, reducing mortality has been already achieved. Treatment rate is expected to be achieved by 2030. However, the problem lies in the underdiagnosis and the lowering the incidence. In Korea, the anti-HCV positivity prevalence is estimated about 0.7 or 6%. However, as all of you know, HBV is still a major cause of chronic liver disease in Korea. Therefore, many attention for viral hepatitis have been focused on HBV rather than HCV. In Korea, as I showed you earlier, prevention of new infection is still lower than we planned, whereas the decreasing mortality has already met goal we planned. This is the fact sheet for HCV in Korea published 2 years ago. I'm sorry about the Korean on this slide. However, you can probably understand what the numbers indicate on this slide. In 2019, there there were a total of 8,810 HCV infection patients. Of these patients, about 78% just visited at least 2 times for HCV infection. Then 74% of them were treated with antiviral treatment. In total, about 58% of patients with HCV infection were estimated to be treated with antiviral agent. These are core indicators relating to the HCV care cascade in Korea. About 6,000 patients were newly diagnosed with HCV infection in every year, and treatment uptake rate ranges around 53% to sometimes 60%. To enhance awareness of HCV infection, our CASL, Korean Association for the Study of the Liver, we advertise to Korean people through the media multiple times. The content of this campaign includes what is HCV, what HCV causes, why do we need the HCV screening. Another effort from our Liver Society is that we also advertise the importance of HCC care to the doctors in private care setting and even dentists. We made leaflets, flyers, or sometimes we provided a poster to them, and then they can hang the poster in their clinic to increase the awareness for their patients. In 2020, we launched a pilot program for national screening for HCV to the general population. For those born in 1964, anti-HCV testing was free by this pilot program. The participation rate was 78%, higher in female. Anti-HCV positivity was 0.75%. And interestingly, only 6% of people participated in this program have been tested for HCV before. The treatment rate after HCV diagnosis was 70%. Based on this pilot program and many previous studies done in Korea, a cost-effective analysis has been published indicating universal one-time HCV screening for general Korean population can be cost-effective if anti-HCV prevalence is more than 0.2%. And as I mentioned earlier, the prevalence of anti-HCV positivity in Korea is about 0.6%. Korean Liver Society discussed many times with our government to launch this one-time universal screening program, especially to be adopted as one of the components in national regular health checkup. And for the next few minutes, I will discuss about what we are doing in a hospital level to improve HCV care, especially increasing HCV testing rate. This is a summary of a study we published last year. Actually, this study was done in a hospital where I'm working now. We analyzed HCV care cascade in a tertiary referral center. Anti-HCV positivity was 1.8%. Only 70% of them were tested to HCV RNA. The HCV RNA positive rate was 65%. And the linkage time from infection identification to treatment, of course, became shorter these days, however, still very long, like almost 3 months. And the treatment rate was below 40%. These are the core indicators, even though it looks like we are going in advance. However, there are lots of things to be better. So in our hospital, we recently adopted a new reflex testing alarm C model, what we call real C model, to improve HCV care cascade. Briefly, if a patient is positive to anti-HCV, our laboratory medicine will do reflex testing for HCV RNA without repeated blood draw. Then if the test comes back positive to RNA, then notification will be delivered to the physician who ordered that test. And if a physician is notified by this alarm system, they should act as recommended, and they should report what they did for this alarm. So when you analyze the effect of our real C model, the HCV RNA testing rate of anti-HCV positivity increased from 51% to 90% after the real C model adoptions. More important point is this figure, I think. Before this model, the HCV RNA testing rate was, of course, the highest in the GI department. However, other departments such as just minor surgery or even medicine, not the GI, was about 40% to 50%. However, after the real C models, all the clinical departments showed 95%. Of course, we did reflex testing, and then at least the testing rate was more than 90%. In addition, the mean interval from anti-HCV positive to HCV RNA testing markedly decreased from 45 days to just 1 day. And this system shows very encouraging results. So I believe other hospital centers in Korea also tries to launch a similar program like us, even though the detailed method would be a little bit different. Okay, thank you for your attention.
Thank you so much. That was an excellent overview. Really a great demonstration of the value of reflex testing algorithms in laboratories where the clinician does not have to be involved in ordering that second test to detect current HCV infection. I guess 2 quick questions, please, about reflex testing. Do you think that's become the routine standard now around Korea, or you think it's still just in certain facilities such as yours that have adopted it?
Thank you for the good questions. First of all, of course, everyone knows the reflex testing will be effective to identify the HCV infection patients. The problem is there's some administrative issues, including the payment, and then sometimes the patients concerned about why they did the test without their consent, even though they already got the consent before. So right. Even though we set up our model very successfully in our center, but I do not think all the probably hospital can adopt this kind of system. But anyways, from the big centers, lots of the hepatologists try to launch the similar system. Of course, the system might be a little bit different in terms of how many patients they are going to cover, and then how to ask the payment to the patient. So those are a little bit hurdles to successfully launch this kind of reflex testing system.
Mm-hmm. And please tell me, just so I understand correctly, the status of routine one-time HCV screening for persons 40 to 65 years of age. Is that a decided policy, or one that's still just in the proposal stage?
Actually, the pilot study I showed you earlier is actually our Korean Liver Society suggests to our government to see the effectiveness of a one-time universal screening program. And then it became very successful. And then we are continuing persuade our government to incorporate this time one-time HCV testing to the regular national health checkup. Korean people are provided a free 5 major cancer screening program every 2 years. So our Korean Liver Society wants this universal screening program putting into the regular health checkup program.
Yes, that would be a great outcome. So that's still being requested, hasn't been accepted yet by the government.
Correct.
But we wish you the best on that. Thank you. Thank you very much. I guess just one quickly. I mean, I know you're, just as a clinician, for routine testing, and when someone's found positive, the person's in Korea. You mentioned that some sort of object to a reflex test, but overall, how do you think your patients respond to being tested and receiving treatment for hepatitis C in Korea? Are they surprised? Or do they readily accept treatment? We hear sometimes people don't want to get treated because they don't feel that sick. Just wanted to see what was the situation in Korea.
Okay, so based on my experience, most
Yes.
of people, they usually don't know about what the HCV infection is. Most Korean knows hepatitis B virus, but they usually do not, they are not usually aware of the HCV. So if they were heard you got the HCV infection, they, like you said, they are usually surprised. I have no idea how I got the HCV infection, and even they usually say, I didn't know what the HCV infection is. So if the HCV is identified, if you just explain the disease and then everything, and then this disease can be curable, and they usually agree the treatment. And then in our report, the treatment uptake rate is about 90% after the hour model. Yeah, but the most important problem is as you expected, the price, the cost of the DAA. In Korea, the DAA treatment, even though it is reimbursed by the National Health Insurance, it's still expensive, like almost $2,500 US. So even though they got the infected and they are willing to be treated, but the copay is still high. That's one of the biggest hurdle.
Okay, thank you very much. Thank you again. Let's move on, just in the interest of time for I see Professor George Lau has joined us and has a question. George?
Yeah, it's really marvelous to hear all the positive actions in Hong Kong and Korea, which is the leading society in Asia Pacific region. I just wonder what type of DAs are being prescribed for those patients you tested positive. What is your policy, and how do you know it works? Because we have different genotypes, and sometimes it's not 100%. So what is the follow-up actions for those people being treated?
Yeah, thank you for the question. So if they were diagnosed to have a HCV infection, the treatment regimen will be decided usually depending on their physician. I mean, depending on the hepatologist. In Korea these days, GP regimen and then Epclusa, they are two most frequently covered used treatment regimen. So there's no big preferences. However, probably the hepatologist will decide which kind of treatment might be better for their patients, considering the comorbidities and then age and then everything.
Thank you.
Well, my question is, are you following up for those patients? Have you follow up on those patients? And what is the outcome of those patients after your linkage to care or service?
So actually, we launched this program just last year. So the thing I can report at this moment is like I showed before, just a treatment uptake rate and how many patients were linked from the HCV antibody to RNA test. But if you are saying about the long-term outcome of these patients, I haven't had any data so far. But after the treatings, the older patients were completely cured. Yeah, I'm not sure whether my answer is satisfactory to you.
That's what I'm asking. Thanks.
Yeah. Well, just quickly on that, I mean, it brings to mind when I talk to other clinicians that we see the long-term benefits of treatment in terms of reducing risk of liver cancer and progressive liver disease, but I also hear reports of patients feeling more immediate improvements in their health, more more energy, more sense of well-being. Do you have patients that have that kind of response to treatment, Dr. Joy?
Yeah, if you're saying about the short-term outcome, like you said, just normalizing the ALT, probably increasing the well-being sense. Of course, some of my patients have a similar experience. Let's say that if they are feeling a little bit fatigue without any cause, the ALT was sometimes fluctuated, they reported, but once they are treated, all the labs became completely normal. Some of the patients, their renal function is also a little bit improving. Yeah, those are probably the short-term outcomes that I have been seeing so far.
Thank you so much. Thank you again. Let's move on so to make sure we have time for everyone. Lindsay, please put for the next screen. And George, please join us. Please introduce our next presenter here. Perhaps George is having trouble hearing me, but it's my pleasure to introduce Professor Kiria Puvaroran.
Hi.
Go ahead.
Hello, everyone. Okay, now I would like to share my slide. Can you? Okay.
Great.
Okay.
Thank you. Please proceed.
Okay. Good. Hello, everyone. Can you hear? Can you see the slide clearly?
Yes.
Okay. Okay. Thank you. And hello, everyone. Okay. Now I will talk in aspect of the Thailand about the hepatitis C elimination program in Thailand. Thailand is the 70 million population country that have quite a challenge because in Thai majority of population is in the rural areas, and in Thailand we have like a lot of immigrants that would be both legal and illegal immigrant population in Thailand. So it's quite the challenge situation. About the epidemiology, about the prevalence of hepatitis C infection, if we look at the new blood donors each year, we can see that the prevalence is decreasing over time, like from 2% in the past to recently, it's around 0.4 to 0.5% among the new blood donors. And recent national surveillance data in Thailand, they found that about 1.2% of the overall population will have the anti-HCV positive. In this group, in male is more than females, and most age that have the highest prevalence is around 30 to 60 years of age. It's around 3% in this age group. In previous several years, we have done the mathematical modeling study to estimate the prevalence and the morbidities and mortalities related with the hepatitis C in Thailand. We, in this modeling, found that the prevalence of the hepatitis C will decreasing over time without any intervention. But based on this modeling data, it showed that the decrease of the prevalence is because of the new incident is quite low, but the decreasing number is because of the mortality related with the hepatitis C. So that is not a good thing, that most of them will die later on. But with the increased treatment coverage, it will show the significant decreasing in the number of the deaths related with the hepatitis C, as you can see in the right figures, and also decrease the annual incidence of the hepatocellular carcinoma. We can increase tenfold treatment coverage compared with the past time. And what about the Thai public health done to trying to eliminate the hepatitis C? The Thai Liver Association make the guideline for national policy for treat hepatitis C that compatible with the Thai public health facilities, and also the Thai Ministry of Public Health published the guideline focusing on the eliminating of the hepatitis C that try to aim at the goal of the WHO aims. And what we have done about the medication in the past, as we know that the hepatitis C drug is quite expensive and widely unavailable, especially in the rural areas. So the thing that have been done to increase the access to the antiviral drugs is to add the pan-genotypic HCV treatment regimen, that the one that used in Thailand is a soft wells. into the national list of essential medicine. It will make all hospitals can access to the drugs in the national drug list, and also remove some barriers to reimburse this treatment, because drug in this, the Thai universal coverage can reimburse it for free, but they have some criteria. In the past, in Thailand, have one problem about the fibrosis criteria. In the past, they limit only one with significant fibrosis. It means that they're free for only one that have the more advanced liver disease. But nowadays, this criteria already removed. It means that all anti-HIV positive can reimburse. And another thing is about to try to minimize the drug cost. Even in the last 5 years, the drug cost is decreasing to around $1,000 with the generic drug from many companies. But now in this year, the Thai FDA have tried to make the drug by themselves, and the drug cost is decreased to around $200 per course of treatment. So it will make it more widely available and affordable. And about the free reimbursement criteria, they try to minimize criteria. In the past, they need to do the genotype. Now, this criteria is removed, and also the fibrosis criteria is removed. Apart from the treatment and the drugs, in Thai, we have some group from the Professor Yo that try to do the micro-elimination in some high endemic province. This is one example of the Phetchabun province. This is one of the 76 provinces in Thailand that have really high incidence of the hepatitis C. The prevalence in this province, based on the survey data, it shows it's around more than 6% of the whole population. It's quite almost 5 to 10 times than the usual population. In this study, they try to make the feasible way to the diagnosis and treatment in this province that have quite a rural area. In that communities, in every community, they will have the primary health setting that have a very minimal healthcare facility. They try to do the rapid test, the screenings, and one that have the positive test, they send the blood to the higher level of the healthcare facility to confirm the INA testing. And one is positive, they have the well-trained physician that to prescribe the medication and deliver the medication. As in this picture, in this project, it will universal screen everyone in the province actively at the age more than 30 to 65 years. I will show you some the preliminary data about this screening program. And as you see in this province have the registered population is around 1 million, and the one that have the target for the screening is around more than 300,000 populations. And the actual number that this project can screen is around almost 90% of the population in the whole province. That's quite a large numbers. And about the positive test in the serology test with the rapid test is around 5%. Among these that have sent the confirmation test, it shows that around 73% have the positive INA testing. And these positive cases, they move into the treatment cascade. As you see in this number, because in last few years, the COVID era, it have some delay in the treatment in this group of population, but now there are more and more cases come into the treatment. As you can see that now it's around more than 70% of them have already achieved into the treatment cascade already, but some of this population did not receive treatment. You can see that in the right hand, about the 70%. There was some case they might refuse to treatment. They don't want to treat. Very few of them is my loss to follow up. And another one major thing is about that is not fit into the criteria of treatment by physician judgment, or even there is not fit in current reimbursement criteria. Because in Thai we have some criteria that, in my opinion, in the future it should be minimized, such as the case with the active alcohol drinking, they're not reimbursed for them, something like that, or the case that have some comorbidities that they seem to not benefit much on the treatment, they did not reimburse to them. So that is one limit problem that I think that should be decreased in the future. And another things, in the prison in Thailand, we have the campaign of the screen all, treat all. This is already implemented in many prisons in Thailand, that they screen hepatitis C, hepatitis B, HIV, and syphilis screening. And in hepatitis C, they treat them all. Such as example of one prison in one province, they screen around 3,000 prisoners and found around 70 positive, and they treat them all, something like that. And another thing, in this year, the Thai government has started to universal coverage program to include one-time screening for hepatitis B and hepatitis C for free to those that born before the 1992, or the one that 30 years of age or elders. They will have free reimbursement for one screening in the right time. And they also include the yearly free screening for those with the higher risk groups, such as those with the HIV, IBD use, MSM, or men who have sex with men, or the healthcare personnel and the prisoners. They have yearly free for reimbursement the cost of screening. And another thing that Thai Liver Society try to do is to increase the awareness. I think this thing is the major problem in many countries, that most of the population did not aware this disease at all, or some population did not know at all what is the hepatitis C. So they try to make the video on the social media, in both the funny videos or most of the heart catching, and show the importance of this disease and how it causes morbidities and mortalities, and also emphasize that it now is free for screening and free for treatment. So to make the more population come into the hepatitis C treatment cascade. But there are some limitations and many future challenges in the Thailand situation. In Thailand situation, we have the registration system, but mainly it's registered based on the reimbursement drugs. But we don't have the active real-time monitoring about the prevalence, about the new infection, or the treatment, the drug that not reimbursed. Sometimes we don't know the exact number on those cases. And about the simplified test to treat strategy for hepatitis C is implemented in some province that try to do, like in Phetchabun province. But in many provinces that might not have good enough to do that cascade, such as in some primary care hospital in rural area, they might not have the link to send the INA confirmation test, something like that, in very like the rural areas. And also in Thailand, the reinfection can occur in many groups of population, such as in the MSM that have IBDU. In that group, many of them have the several episodes of infection even after treatment. And also the screening program is now free. The treatment is free on criteria already, but it's still passive. It means that most of them need to visit the hospital by themselves, the active screening that some healthcare personnel go to into the communities. It is not widely implemented, just only in some areas. Okay, that's all about the pictures of the hepatitis C elimination in Thailand. Okay, thank you very much.
Thank you very much. Excellent overview. So much information. I greatly appreciate it. You really gave us a good overview of the new universal screening program and removing treatment and testing costs as a barrier for patients. So congratulations to Thailand for bringing that about. And you touched on, and partially answered a question I had, which was, how is that testing recommendation getting rolled out and getting adopted? Because at this point, it's all about testing, right? I mean, that's the only way to find the treatment, people that need treatment and get them on the treatment. So, with your experience in other nationally supported screening, perhaps for colon cancer, for example, or breast cancer, what do you think is needed to roll out this universal testing recommendation so that it will be adopted by primary care clinicians and others? Do you have any ideas, please?
Yes, because this implementation, it needs a lot of effort, because now the public health policy is only free for testing, but the way to implement this free testing is quite challenging. In my opinion, I think that each community, they should have some like the public campaign to enroll those in the communities to get tested. But I think it might be in different way based on each community, something like that. But at least the first key have already started that it's free. But the implementation, I think it's quite much challenge on that. Yes.
Okay. And quickly, we heard about the benefits of reflex testing in Korea. Is that type of strategy done in the laboratories in Thailand?
The reflex testing is not done routinely. It still need the way to request further confirmation tests. But in the campaign or in the implementation, sometimes they have like the flow to do like the reflex testing. But in general, primary care, they still need to request another testing to confirm.
Okay, thank you. And there was a question in the Q&A section about testing in prisons. And is that a ongoing program, meaning as prisoners come in, they are tested? Or is that a program that was only done for a study, or is only done, at certain times?
In several prisons, they done like the routine practice already. It means that all new prisoners, they will screen all these infection. But now it's not implemented in all prisons in Thailand. Just some of them. But by policy, they try to do it all.
Yeah. Well, it's off to a great start. Thank you very much. Let's move on to make sure we get to everyone. So Lindsay, just please put up the next slide. And it's my pleasure to introduce my colleague and co-editor of a recent supplement to the Journal of Infectious Disease. We brought together a number of interesting articles and of reports on different strategies for hepatitis care and treatment, and I encourage you to look at that supplement that was published in September. And my colleague is Professor M.L. Yu, who's the Dean of the College of Medicine, Director of the Doctoral Program of Clinical and Experimental Medicine, Center of Excellence for Metabolic Associated Fatty Liver Diseases, Senior Vice President, National Sun Yat-sen University in Taiwan. ML, turn it over to you.
Okay, thank you very much, John. Okay, let's share this. Okay, good morning, ladies and gentlemen. It's my great pleasure to have the chance to share the key strategies and milestones for HCV elimination in Taiwan in 2023. The key strategy almost that we are doing the ongoing national plans in increasing the disease awareness by using the mass media campaign, to expanding the screening population by using the one-time test for HBV and SCV program for all adults aged between 45 to 79 years old, or 40 to 79 years old for indigenous people, and also to reimburse the reversing test to increase in the speed and the rate of diagnosis, and allow the outreach screening, diagnosis, and treatment even in the community, not the clinical settings, to all the populations, to provide the so-called decentralization and integration program, and also empower all of the physicians, whether the specialist or non-specialist, they can prescribe the DAA, so-called the task sharing. And recently, the government has set the HCV surveillance as a key quality assurance for hemodialysis patients, and also advocate the easy access for the screening service for all of the newcomers in prisons. And more recently, we collaborate with the Society of Diabetes in Taiwan to make the consensus guideline for routine screening and management of HCV among patients with diabetes. This is the consensus guidelines collaboration among Taiwan Association for the Study of the Liver, the Taiwanese Association of Diabetes Educators, and the Diabetes Association of the ROG Taiwan, just published in early in this year in Journal for Most Medical Associations. The key recommendation is that all the patients with diabetes should be checked for anti-HCV once in a lifetime, combined with the HCV RNA depression testing. And for the HCV RNA positive patients with diabetes, we recommend a simplified anti-HCV treatment algorithm with fiber specialist or non-specialist. As you can see in the right side tables, the eligible for TASER is the Taiwan Association for Study of the Liver Committee, HCV Registration Committee. The TASER simplified treatments include all the patients, the patient with chronic HCV infection with life expectancy more than 1 year and have no prior DA treatments. And if they have no exclusion criteria, such as current or prior hepatic compensation, the non-hepatocellular carcinoma, HBV or HIV co-infection, prior organ transplant, or FIFO greater than 3.25, and current pregnancy, they can be assigned into the so-called simplified treatments by the non-specialist with the pan genotypic DAA, whatever, Solvair or Glipit. And if the patient have age more than 70 years old, or EGFR less than 60, or total bilirubin level at baseline greater than 1.2 milligram per deciliter, they're at the risk of grade 3 or grade 2 to 4 adverse events in the risk of the abnormality, especially the elevation of bilirubin level, AST and ALT level. For this population, we recommend they have to be consulted by the GI liver specialist, and then move back to the non-specialist for the simplified treatments. And here is the key milestone for HCV elimination in this year. The first one is the rolling evolution of HCV seroprevalence map. In the figure, in the left side figure A, you can see is the original township specific risk map of HCV by incorporating 7 township specific surrogate index of HCV risk established in 2017. The surrogate including such as the HCV prevalence rate in hepatocellular carcinoma, and the data from the National Health Insurance Administrations, and also the data from NGO community screening. And recently, we updated and revised the HCV anti-HCV seroprevalence map by using the more precise prevalence rates based on about 2 million participants in the mass screening program to July 2022, and also adjust by the birth years. And then you can see the newest anti-ICV seroprevalence mapping was this was demonstrated in the right side figure. And with this map, we can provide the data to make the nation plans more specifically to the to each township based on their predicted anti-ICV prevalence. The second milestone is the progress report of ICV care cluster in general population as well as in the spatial population. As you can see, the top is the spatial population. The screen rates were very high in patients under hemodialysis at 100%, patients with HIV at 97%, but much low in the prisoners, just only 40%, and 77% in the opinion substitution therapy patients. But if looking at the RNA testing rates, it's almost all the subgroup have the RNA testing rate more than 80%, and undoubtedly more than 90% of the RNA positive patients have been treated. If looking at the patient with comorbidity, you can see the anti-ICV screening rate is low to 55% in diabetic patients, to 66% in pre-ESRD patients. And again, the RNA testing rate was around 70% in all of the three comorbid population. But you can see the treatment rate was even very high, more than 95%. How about the data in the general population? As you can see, in the base of around the 10 million general population, age range from 45 to 79, the anti-ICV screening rate was 40%. And RNA testing rate was 67%, and again, the treatment rate was 96%. The anti-ICV screening rate and the RNA testing rate was a little bit low in the township of low-risk areas. This is risk level 0 to 7, only 78%, 37.8%, and 65% respectively, and reached 50% in anti-ICV screening, and 75% in RNA testing for the township with moderate to high risk areas. But all of the treatment rates was around 95% or more. So we recently tried to establish a roadmap. It's a website initiated by the Taiwan Liver Research Foundation in collaboration with the government, the Taiwan National Hep C Program Office. And this website will be launched formally in the end of December this year.
Welcome to the tutorial for Taiwan Hepatitis C Elimination Roadmap webpage. The goal of this interactive webpage is to provide the latest view of Taiwan HCV elimination status. In the right-hand side, you can see elimination status for all Taiwanese population and how it compares against WHO's targets. This data are being updated on a quarterly basis. To further drill down by geography, you can easily move your cursor over the map and click on the county of interest to obtain data. The different color shades shows the execution rate, darker means more percentage achieved. This bar graph provides the number of estimated and treated HCV patients by each county. You can also explore by county elimination status for various high-risk populations, including HIV, ESRD, and PV, who receive methadone replacement therapy. The setup is similar to the map in the homepage.
So in this roadmap, we also provided the progress of the national strategy programs by the government. For example, this is the milestone, the time slot for the simplified service delivery for HCV, and recently the government advocated integrating the nation plan to all of the clinical setting and all of the so-called interdisciplinary health service to increase the accessing rates and as well as the diagnosis rate. And also this is the nation has insurance reimbursement and treatment criteria. And right now we reimburse the HCV antigen testing, and also allow all the licensed physician to prescribe the DAA. Thank you very much for your attention.
Fantastic. Thank you so much, ML. I just have one clinical question. Because of the high prevalence of hepatitis B in Taiwan, there's always been a concern about sort of a reactivation of hepatitis B as hepatitis C treated and cured. And I noticed, of course, you have a recommendation of screening patients for hepatitis B before the treatment of hepatitis C is started. But I just wanted to learn from your own clinical experience. Have you had many adverse events with hepatitis B infection following cure of hepatitis C, or while they're on treatment for hepatitis C?
Yes, I think it's a critical issue in the HBV/HCV hyperendemic area, such as in Taiwan. So the National Health Insurance Administration's request all the HCV patients need to be checked surface antigen and the anti-HBs antibody before prescribing the DAA. If the patient positive for surface antigen, they can apply the reimbursement of NUC therapy for this patient population if they meet the criteria of reimbursement. If the patient does not meet the criteria of the NUC reimbursement, we have to monitor the patient carefully during and after, and up to 6 months after the DAA therapy.
Mm-hmm.
And we also recommend all the cirrhotic patients had to be prophylactic with a NUC to prevent the HBV reactivation with decompensation.
Yeah, that sounds good. And maybe we have time to ask this of all the panel who are on our webinar today. But there is a saying in disease elimination that national commitment is as important as technical know-how, and the national commitment or the government commitment there is quite evident with these really thoughtful policy development and program development. What do you think were some of the reasons for that national commitment of the government's commitment? Is it some kind of cost effectiveness modeling, or is it the long experience with hepatitis, beginning with hepatitis B in the 1980s, and so it's a very well informed government, or some other reasons that you think explain the strong government commitment to hepatitis testing, care, and treatment? Any thoughts on that, Emil?
I think that the hepatitis research is quite popular and have high reputation in Taiwan. So we have very famous researchers such as Professor Xile Chen, Professor D.S. Chen, Professor Jia Honggao, etc. So we can provide the evidence, not only the cost effective, but also the benefit for the people who infected with this virus. So after the launch of the first HBV mass vaccination and its success in decreasing the HCC risk in the young adults, it provides a very powerful evidence for the government to follow the recommendation by the research group, about the academic groups. So I think it's the most important that we have to provide the robust evidence from the scientist research. The second one is the organization, not only the NGO, but also the academic society. So the Gastroenterology Society of Taiwan, the Taiwan Association for the Study of Liver, play an important role in the committee of the Taiwan CDC. So it's very important that we have every 6 months we have a committee, the nation committee, discussing about the prevention and treatment of viral hepatitis. So I think the committee is very important. It's almost 30 years in Taiwan. And finally, I think is maybe is also very important because we have Professor Xi Chen. He was the prior vice president of the Taiwan, and currently she is the prime minister of Taiwan. So I think it's very important that we can have the key persons. They serve as the important role in the government.
Absolutely. Very good. Excellent. George, you have any questions?
I think this is an excellent webinar organized by you yourself and Global Hepatitis Elimination Coalition. I want to make a few comments on behalf of APASL, and this is exactly what we want, the linkage to care. And there are two factual things that is happening in 2023 and beyond. Point number one, we now have the technology know-how of testing, getting rapid results in terms of hepatitis B and hepatitis C. And point number two, we have available therapy for them at a very low cost, especially in Asia Pacific regions. And unfortunately, the point number three I want to bring out is the liver-related mortality and morbidity is increasing in terms of liver cancers and also end-stage liver cirrhosis in Asia Pacific regions. So there must be something needs to be done. And I think that this is exactly what the coalitions working closely with APASL might help to shape the government policy, because this is obviously cost effective with the low cost of the testing now made available. We are not talking about old days when I work with people like Yun Fan Nell and so on. At that time, the testing is very expensive. Now you can also learn from our COVID experience with all the machineries we have, with all the PCR testing we have in the 2020 to 2023 during the lockdown. So I think that a joint statement on behalf of APASL, and I would like to invite all, including you, your asset advisors, to Asia Pacific regions where liver cancer and end-stage liver cirrhosis is still a major cause of patient suffering, and how we are going to close the gap to not to talk about to achieve the WHO visions statements of 2030 of 65% reductions of the endpoint. The viral eliminations is a step, but the endpoint is the suffering from liver cancer and also end-stage liver cirrhosis. So we are far from that, and I'm glad to see initiatives in Hong Kong, Taiwan, and South Korea. We have a strategy, but this needs to be expanded tremendously. We are taking care only of very small populations, and always Taiwan initiates 40 years ago with universal vaccinations of hepatitis B. And this is now the time we should go forward to have a universal screening and linkage to care to further tackle the problems. What our Taiwan colleagues like Zhao Meigui to start with the universal vaccination for hepatitis B. But at this time, I think really is good timing, because the cost is drastically reduced with all the PCR quick test and the linkage to care, and also with all the technology platforms with smartphones, and we can trace and track. And this is a very good moment, and I really hope that there will be some good effort concertedly to take care of these problems, especially in Asia Pacific region.
Thank you so much, George. That's fantastic. I couldn't agree with you more about about the call for action. I mean, I don't think anyone should be dying of hepatitis C any longer with these treatments that are so effective and at such an affordable cost. And it's really a question of getting the national commitment to scale up testing and linkage to care. And we're hearing of some examples on the webinar. We have one more presentation from Singapore. Lindsay, if we could go to the next slide, please. Let's see, is this, please proceed. I don't have your name right in front of me.
Yeah, it's okay, Prof. John.
There we go. Sorry, Professor Chow Yu, pardon me, Senior Consultant Hepatologist, Tan Tock Seng Hospital. Please proceed. Thank you.
Let me share my slide first. Can you see my slide?
Yes.
Okay. Thanks, Prof. John, for your kind introduction. And I would like to actually extend my gratitude to the Task Force for Global Health to invite me to give this important talk from the perspective of Singapore. This is my disclosure. And I once asked Professor Vincent Wong from Hong Kong on how we could actually measure hepatitis C diagnosis in the country for the program. And I'm glad that the WHO has also recently published a guidance for country validation for viral hepatitis C elimination. And in terms of the validation to be done in the several domains such as hep C transmission, liver-related mortality, programmatic targets, and also prevention target. So it's just come time to be handy to me and to many of us, I think. And today, I will choose to actually focus on the programmatic the targets in the treatment and what is actually the Singapore progress and also the insight. I summarized the landscape of hepatitis C microelimination effort in Singapore today, and we have some plan for the outreach programs for other key population apart from the PWIC group, in which we have been working on for quite some time, and I have been heavily involved in the Educate, Test, and Treat program. We have also some. We have actually extended to other key populations such as LGBTQ and people with sexual risk, and through the NC initiative, through a platform for National Foundation of Digestive Disease in collaboration with Pink Dot, and we plan to work with hepatitis C mobile testing service action for AIDS anonymous testing service also in the next year in 2024. We are also in the discussion with the Institute of Mental Health for the program in addictions detoxification program. And currently, we do have some stable program for hemodialysis surveillance and also pregnancy and surveillance in the pregnancy and also the HIV cohort. And while for the general population with the risk factors, mostly is actually, we are using the outreach, the public talk in terms of annual World Hepatitis Day public forum, in which is actually an annual event, and also we plan to have actually interesting perception survey in the young Singapore adult from Hep B and Hep C in next year. So, however, we don't have any active screening for the blood transfusion before 1992, and there's no active screening for the foreign workforce at the moment. So my talk today will actually concentrate on the PWIC group in the halfway house, which is actually a community-based corrective institution. And the program highlight here is actually we do have some component on the education, diagnosis, linkage to care, and also treatment. So if you can remember the slide from my slide from the APASL February 2023 Policy Forum, and halfway house, it's actually fall under the aftercare of the Singapore Prison Service. And we through the collaboration with HCSA, High Point, and my hospital, Tan Tock Seng Hospital, through the Educate, Test, and Treat program, has enabled us to actually, have a chance to see what is actually need to be done for the Hep C elimination in the period group. And this has also primed our interest to generate the NC initiative through this opportunity. So what is actually the program development for the ETT? So we have made great progress in ETT with a recruitment starting the recruitment drives since 17th of March 2022. Then we followed by the official launch of program in July this last year. And this was actually followed by the participation of other halfway houses such as Teen Challenge, Tularang, and also the Helping Hand. And we completed the recruitment in April 2023. We analyzed the data that we want to see. And this have been followed by the signing of a memorandum of understanding across 5 major halfway houses in July this year to see that Hep C is a national problem that we need to actually address. And from here, there's actually primed the program further. We are delighted to have the Suzy charity organization on board to assist the DAA cost, which is actually still costly in Singapore, and together with an unrestricted grant from the Gilead to support the non-DAA cost. So what is actually the some important outcomes of the report from the ETT program was that we actually reported the Hep C prevalence is actually quite stable compared 10 years ago, report from the 10 years ago, which is about 37.3%. And we noticed that the ETT is actually not immune from the breakage in the chain of survival of the Hep C elimination. And there's actually a high attrition rate from the RN testing, which is about 53.8%, and the DAA treatment attrition is about 73%. So what is the factors to actually explain this observation of uptake in the diagnosis and treatment? So we quickly analyzed, went through the process, and we noticed that the DAA cost in Singapore, although has been reduced significantly over years, back in 2018 through the value-assisted pricing negotiation by the ACE, 85% reduction in the cost to the patients was achieved. And this is very encouraging, and together further top up with a medication-assisted fund has further supported 11% of the cost. And of course, the Singapore government will expect some co-payment, same as the other diseases, about 4%, out from the pocket of the patient. So, however, in this ETT PV group, it's actually a little bit challenging because as what you can see, the inmates occupation, the unemployment is about 70%, and those actually, in the social reintegration back to the society, mostly they are engaged with occupation with skill level 1 to 2, and then it's actually encompassed up to about 93%. And even a co-payment, as small as a few $1,000 could be a whole month's salary for many. So, and this have been identified as a major barrier to access to the DAA. As to give you some granularity about the Singapore's finance assistance assessment structure, the treatment subsidy and financial assistance structure in Singapore, the DAA is actually considered as a high-cost medication in Singapore, and we do have a GP and software that are listed under medication assisted fund, and we have the software box under a separate fund called the MAF Plus with a more stringent criteria. And those actually, to assess eligibility, you need to get assessed from the monthly per capita household income, in which the applicants need to submit documents for those actually staying under the same household, the same address. So, and as what you can notice here, Singapore citizens and permanent residents have a quite different criteria for eligibility, and the patients who cannot afford the co-payment will require a separate social worker assessment for Medifund assistance. So this is what happened if you actually follow a standard workflow. If you can see the green bar, this demonstrated the projected waiting time, the longest waiting time as barrier to initial DAA from the time a patient is diagnosed with a chronic Hep CV. And the major hurdles here is actually the finance assistance application approval could take up to 5 to 6 months from the diagnosis, and remodeling of the Hep C linkage to the care cascade for an enhanced workflow is actually really required. This is actually what we actually plan to do. Is actually we collapse the blood test to inclusive of FIT4 to identify the patients who is actually have a significant liver fibrosis, and also abdominal examinations to make sure that those actually fibrosis is not in the decompensation, together with interpretation of a liver function test at the first consultation of Hep C clinic. And the background, we don't have a POCT RNA test, but we actually, when the patients come to the Hep C clinic, we did tests, Hep C RNA test, and we trace it at the background. And on the second week, we trace the RNA report in week 2 to initiate the finance application. And week 4 will guide the FibroScan assessment to see whether the patients actually need a long-term surveillance or not. But this is actually there's no urgency for the immediate completion. So with that, with this care remodeling for ETT phase 1, we are recalling the defaulter, and this is actually a proposition for us to actually proceed to the ETT phase 2. The provider care coordination between the clinician, pharmacist, and finance department, and halfway house coordinators is actually what we are actually looking into. And it will actually aim to actually shorten the chronic Hep C diagnosis or DA initiation time from 5 months to 5 weeks. And this, there's actually recent evidence published by the Australia systemic review meta-analysis. A 45 study described the implementation of the intervention to improve Hep C testing, linkage to care, and treatment institution among the PWIT. And the author, have commented that the important point here is actually a point of care antibody testing with a linkage to care, and the integrated care in the linkage to care, and also the treatment initiation. So what is actually the insight from the ETT program and our future plan here? I would like to summarize the insight and the solution. And we also find that the venipuncture could be difficult and impossible sometimes. It's actually very labor intensive, and there's actually some occupational health has a risk. And we will actually consider the point of care test, avoiding a venipuncture if possible. And for the anti-Hep C serology, the current program, Singapore Hep C serology, have fluctuates between 30 to 38%, and it's actually quite stable. And there's actually a model prediction that we don't, just follow the standard pathway without, the care remodeling, that will demonstrate a slow decline in the Hep C incidence without any intervention. We propose active screening for Hep C linkage to care of a treatment, periodical surveillance of the anti-Hep C serology for those actually have not exposed to Hep C before. And for those actually defaulted the Hep C RNA testing because of a complex social behavior background, and also a recidivism rate for the drug-related offense remains significant over the years. And we think that we need speed. And for the early confirmation of a chronic Hep C state and the linkage to care, and this need a lot of coordination with a halfway house coordinator, the support outreach education program for the awareness. And for the chronic Hep C, nearly half of the Hep C exposed population in the ETT may remain viremic infectious, with about 50% of them for the data that we have. Without any intervention, we have been actually calculated the PWIT chronic Hep C rate is estimated about 3,000 by 2030. So we should actually upscaling of Hep C diagnosis, a treatment-related program in corrective institution aftercare program, and prison and also halfway houses. And while for the attrition rate from the DA treatment, there's challenges in the finance document collation and complex social behavior background gain and recidivism of the drug-related offense. And for this, we are looking into multiple finance assistance, streamlining the application for the finance assistant and coordinated care with halfway house coordinated support. So lastly, I would like to take the moment to express my gratitude to HCSA High Point staff for their exceptional contribution to the ETT project. So Sean, the head of HCSA High Point, Gerard Wong and Samuel Wong, the senior executive, and also Rary Sosiago, the Hep C SA alumni, a past Hep CV patient who actually get cured with a motivation to join as a force for the current case coordinator, and their constant dedication has ensured the progress of the ETT. I would like to actually share some further insight on the systematic review meta-analysis, published and then by my team on the impact of a direct active antiviral to evaluate the impact on DAA on 5 liver-related outcome, the Hep C, occurrence, recurrence, all-cause mortality, liver decompensation, and liver transplantation. And we did see tremendous benefit of DA therapy. If let's say a disease is actually diagnosed early and treated early, and it might not be constantly observed across all groups with different baseline liver status, and we ensure the highest quality possible by only only select the randomized case control and cohort study. We found that DA reduced Hep C occurrence significantly in the non-cirrhotic and cirrhotic, but not in the decompensated cirrhosis, giving us a message that this disease is need to be actually diagnosed and get treated early. And DA did not actually prevent a liver transplant. And in terms of cost, economic analysis, and cost saving, the ACE have a publication in 2022. And for the subset listing since 2018 in Singapore, the modeling over 5 years, patients called the progression to liver failure, cancer, and death. And the subsidy decision could actually result in the saving of a healthcare cost of 39 million. So my conclusion here is for Singapore, where are we? Hepatitis C microelimination efforts are showing some promising progress. Although the economy slowed down and inflation could impact on the program budget. So provision of the financial aid for the medical expenses remain a critical obstacle for us, and the multiple funding sources are needed to ensure access to medical care, to ensure them is actually remain affordable. Although equitable to healthcare access is very important, but there's some consensus approach that should be taken to address any potential sensitivities involved. Thank you for your attention.
Thank you for an excellent presentation. Great and very interesting to hear about the status in Singapore. So thank you for bringing that to our attention. You mentioned the subscription model for hepatitis C treatment, whereby at one cost you can treat a unlimited number of patients. That's typically the case. So that really helps solve a problem on a budget for the treatment. I'm interested also in the your approaches to preparing the workforce to deliver that treatment. What's the role in training that you put in place to and were primary care doctors as involved as specialists were in the delivery of care for hepatitis C in Singapore. Thank you. So were there any particular challenges in training non-specialists to provide treatment for hepatitis C in Singapore as part of this program?
Yeah, sorry, Prof. I can't, because of connection problem, I can't really hear you just now.
Okay.
Okay. Yeah, so that's actually clearer. Yeah, we do have some, training program. I would like to actually divide it into the halfway houses, because we are actually using the HCSA High Point as the model for us to actually build as just a pilot in which we are training our HCSA coordinator, Larry, to go through the process by accompany their clients to actually come to the hospital and then the whole hand with them. And we did actually going down at a regular basis to the halfway houses to give the talk. And to actually have engagement with all the halfway houses, the personnel. And we actually also actually in the process of the discussions of whether they can incorporate Hep C elimination, the program, education program into their routine kind of, the aftercare program in the halfway houses. And well, for the general practitioner, it is mostly actually driven by the individual hospital to actually organize a yearly event to actually engage the GP, the general practitioner to actually choose a topic on the Hep C elimination. But Singapore is actually very small. I think as compared to the bigger area like the Australia and the US, and then probably actually because of the logistic issue that we actually it's actually beneficial if let's say we can generalize just like Taiwan to the GP and also non-level specialists to actually prescribe the DAA. However, in Singapore, because the population is actually also relatively smaller, the population is actually in the vicinity to the hospital, to the major hospital. At the moment, we still haven't actually generalized the GP, but we did actually have some engagement with them for referring the cases, and then we actually there's some program to allow the reflex testing at the GP level. Thank you.
Thank you. Thank you so much. And thank you again all for an excellent set of presentations. I am so appreciative of you sharing your expertise and lessons learned in your programs in all the countries represented today in this webinar. So thank you again. I want to thank my colleague, George Lau, for representing APASL, who's a real strong partner in sharing this information broadly. And we look forward to seeing all of you at the APASL annual meeting in Kyoto in 2024. Before we sign off, please participate in the evaluation poll that was just up on your screen. And just want to remind everyone, if you come to the coalition website at globalhep.org, you'll see some what we call hepatitis elimination profiles that provide information regarding the plans, the policies, the programs, and progress toward elimination. And most of the areas that are represented on the webinar today, as well as an additional ones that you can see here. And I think you'll see that they have immense value. And indeed, some of the information from these profiles were shared in the presentations today in the webinar. So thank you again for an excellent set of presentations, and I look forward to future opportunities to work together, and hope to see all of you at APASL 2024. Thank you. Take care.
Thank you very much.
Thank you very much. Excellent work, guys. Really enjoyed it. Thank you so much.
See you soon in the Kyoto.
See you, hope to. Bye-bye. Thanks again, George.
Thank you so much, everyone.